just continue to talk about the adult with hypertension. There's so much that I could present to you. I've tried to just take 4 different areas, and I'll summarize that at the end, of what I think are the real key messages that we should be thinking about when we see our patients with hypertension. Since 1972, when Elliot Richardson was the Secretary of Health, Education, and Welfare, HHS now, we've had a group of experts that have gotten together and developed what's called the Joint National Committee Report. The first one was 5 years later, when hypertension really was put on the map in 1977. And every 4 years since then, we've had a report that has come out until the 7th report came out in 2003. It will be 9 years, 5 years in the making, that we will have a JNC 8. It will be presented in a preliminary form along with the lipid adult guidelines and the obesity guidelines in November, the pediatric guidelines as well, but it will not be in its final form. And the final form, we're told, will not come out until March of 2012. So what I'm going to talk to you about are some of my ideas on what I think JNC 8 really should discuss. A lot of this is extremely controversial, and I'll tell you, some of it is going to rock your boat just a little bit, because a lot of what you've thought has been based on opinion and not hard clinical trial evidence. And that's something that I think we all understand, and that is that medicine is an evolving science, and hypertension certainly is an art in its practice, but also is an evolving science in its evidence base. So here are my financial relationships. So why are we still talking about hypertension? Because it's the most common reason people come into your office day in and day out and get chronic prescription medications, and there's a tremendous amount you can do for it in the adult, for sure. About 74 million have it, just as many have prehypertension, a blood pressure of 120 to 139 and or 80 to 89, not quite hypertensive. But if you follow them long enough, many of them may go on to develop true hypertension. And as Steve's already told you, in the adolescent as well as in the adult population, we're living longer, you're more likely to get systolic-only elevated hypertension, and we're more sedentary, more obese, and we're more likely to have hypertension. So the prevalence of hypertension is increasing. That said, if you get blood pressure reduced to a minimum goal of less than 140 over less than 90, you can do tremendous good for your patient. You can reduce the first evidence of clinical heart failure by 50%, first evidence of stroke by 40%, and first evidence by MI of 20 to 25%. And as Dr. Roberts told us last night, stroke is really the most blood pressure dependent variable. And if you looked at Dr. Daniels' data that he presented on that first slide, you'll see that in what some might call normalish blood pressures, that is, blood pressures until you get to about 140, heart attack was much more prevalent than stroke, but once you get to 150 and above, stroke is a much more blood pressure dependent variable. And this will come into play when I talk to you about the ACCORD trial in a couple of minutes. This is a very important slide that I put together. It's a 20-year follow-up of the National Health and Nutrition Examination Survey. And it shows you very much how the prevalence of hypertension has increased, how more of our patients are aware of having hypertension. Only 1 out of 5 Americans walk around with hypertension not knowing it, and that's shown here. And more of our patients are being treated. Now, overall, we often say that we've done better in the control to less than 140 over less than 90, with 50% of adult Americans 18 years of age and older controlled to less than 140 over less than 90. But that's a little unfair to us practicing clinicians, because if you look at those that come into our office knowing that they have hypertension and on therapy, we actually have risen to 69.1%. That is, 7 out of 10 18-year of age and older Americans with hypertension that know it and are taking drugs are less than 140 over less than 90. So we will continue to do better than this. A lot of it is a systems approach to blood pressure control, that we eventually, hopefully, will have better systems. We'll be able to see a dietitian, a PharmD, and all be bundled into one particular ICD-9 code. But for the time being, we are doing better in the control of blood pressure. Now, I'm going to make some predictions. It's hard to make predictions. I turn to Yogi Berra. Of course, we had Confucius, and Yogi said it's tough to make predictions, especially about the future. So a couple of important points. We reduce outcomes, we improve outcomes, reduce target organ disease when you reduce blood pressure. And at least in the adults, systolic blood pressure tracks much better than diastolic blood pressure. And as you reduce systolic blood pressure, you reduce stroke, major cardiovascular disease, and death, total death. Nothing better than preventing someone from dying in controlling their blood pressure. And what's not often appreciated is that you cannot out-trump blood pressure reduction in those that do not have a compelling indication for a particular drug or drug class. And that is that no clinical trial has ever shown in the adult that a patient will do better, no matter how sexy you think that drug is, will do better if you haven't at least lowered blood pressure as much as the comparator in the trial. And that's shown very nicely here because the univariate risk is shown here, and there's no benefit to an ACE inhibitor compared to a diuretic with or without a beta blocker for major cardiovascular events, cardiovascular death, or total death. There's no benefit to a calcium blocker compared to a diuretic or a beta blocker for major cardiovascular events, cardiovascular death, or total death. And there's no benefit to an ACE versus a calcium channel blocker. Even though there are small differences in blood pressure within the trial, there's no difference in the risk. Blood pressure reduction out-trumps the benefit any particular drug you think you're using in those that have uncomplicated, if you will, hypertension. There are a couple of outliers. Let me show them to you. For stroke reduction, CCBs are a little better than ACE inhibitors. For heart failure, the diuretic is better than the calcium blocker, and the ACE inhibitor is better than the calcium blocker. So outside of those exceptions where a CCB may be part of the cocktail in a stroke-prone individual, or a diuretic, as I'll show you in the ALLHAT trial, is part of the cocktail in someone prone to heart failure to prevent first evidence of heart failure, or with heart failure, where an ACE inhibitor is best in those with hypertension. These are the only exceptions to one particular class of drug being better than another, even with small blood pressure changes for hard end organ endpoints. I want to also talk about the second area of my talk on blood pressure measurement, because it all starts with blood pressure measurement, and it is difficult in the child or adolescent. It is not as difficult in the adult, but we make it so. And this particular cartoon shows you many different areas of how we are inexact in how we measure blood pressure. We don't talk to our patients, at least we shouldn't. We shouldn't have the sphygmomanometer on the wall. She shouldn't be startled by what we're saying to her, and she shouldn't be having her feet up on the table. And the problem here is that many of us have the patient jump on the table and have their blood pressure taken. All of the things I'm showing you in the circles will falsely raise the blood pressure. She has pressure on her arm through her fingers pressing off the table. That will raise her pressure. And the cuff size is so important, as we're showing here. So these are all very important areas for a falsely elevated blood pressure. Patients should be seated in a chair, quietly resting, no smoking or coffee for at least 5 minutes. They should have their blood pressure taken with the cuff at heart's distance. And this particular automated device from Canada called the BP True device is one that we're really looking to for future clinical trials. Let me just say that as much as I like to put a blood pressure cuff around my patient's arm and take the blood pressure myself, I know that there is inter-individual variability, observer differences, that do not allow us to ever have physicians take blood pressures in a clinical trial. You all would have our hide if you knew that in 623 clinical centers, where 2 to 3 people were taking blood pressures in each trial center in the ALLHAT trial, that they were being taken by different physicians or different nurses. Instead, we use an Omron automated device, the same device sent to every center, and we standardize how blood pressure, and we test people on how they're going to use the device before we even do the clinical trial. So that's very important. This is an interesting device. This is used in Canada. This was done in 50 patients. They take 6 readings. The first reading is taken by the physician. The second to the 6 readings are taken with the patient sitting in the room. So you press a button, you take 6 readings, you leave the room, it's a darkened room, you're not talking to the patient, their feet are on the floor. You throw out the first reading because that's the white coat or alert response, and you average the 5 successive readings, and that is your blood pressure. So look for automated devices in the future. Look for JNC 8 to recommend automated devices. And some of the devices we use for our patients that they use at home are automated. One caveat, the diastolic blood pressure is calculated. The systolic blood pressure is measured. What about home blood pressure measurement? I'm a big believer of home blood pressure measurement. This is a nice study in almost 5,000 individuals who were elderly. They used the Omron 705, followed them up for over 3 years. And the point of this study is that although the metric is office blood pressure, you're only as good as your last office blood pressure. Actually, home blood pressure correlates with prognostic significance extremely well. Notice here that even in those that had a high office reading, it was the home reading that predicted outcome. Home blood pressure was more strongly related to target organ damage and cardiovascular outcomes than office reading. If the home reading was normal, but the office was high, the outcome was much closer to the normal than if the home reading was high. So in the future, I'm hoping the government will allow us to use home readings as an acceptable metric. And in the future, I hope clinical trials will look at home readings for outcome improvement. Just a couple of summary points on this. There's inherent variability in the in-office blood pressure, and often you only measure it every 3 to 6 months. Home blood pressure predicts the risk of cardiovascular events better than conventional office measurement, but we are not allowed to use the home blood pressure measurement as a metric. If checked at home, patients are more likely to adhere to their medication regimen, and they're more likely to get their blood pressure controlled. Greater than 130/85 is considered abnormal. That is hypertension at home, 140/90 in the office. And how can you do it? Well, you can tell the patient to check their blood pressure for 1 week out of every month. They take it 2 to 3 times in the morning and in the evening. They throw out the first day of the week, and they average the other 6 days. And they can repeat this 4 times a year. This is being looked at as a validated way of using home blood pressure measurement without making the patient a slave to their measurement, where their anxiety and their concern for the blood pressure can often impact their day-to-day readings. Second clinical point. We currently recommend from a number of good organizations that in the diabetic, blood pressure should be less than 130 over less than 80. JNC 8 may make changes to this and many other guideline recommendations, with the blood pressure threshold being a little higher than you're used to seeing. Here are the current recommendations: less than 140 over less than 90 for all, less than 130 over 80 in those with diabetes and chronic kidney disease. Let's look at how we got to these guidelines. The less than 80 in the type 2 diabetic comes from the HOT trial, the Hypertension Optimal Treatment Trial. Almost 19,000 patients with hypertension done outside this country and double-blindly randomized to a goal of diastolic less than or equal to 90, 85, or 80. The achieved blood pressure was 85, 83, and 81. In the overall trial, there was no difference in lowering 81 to 85. Outcomes were not improved at less than 90. However, in the 1,501 type 2 diabetics of the almost 19,000 in the trial, there was a 51% benefit that lower was better for cardiovascular outcome. And this is how we get the target of less than 80 in type 2 diabetes achieved 81. What about the systolic? The systolic of less than 130 comes more from kidney disease outcomes in diabetics than from cardiovascular disease outcomes. In fact, if you look at the diabetic subsets of a number of different trials, you'll see that we never got below 140, and yet the outcome was improved when there was a 12 millimeter difference, a 9 millimeter difference, and you can see the differences here. Small differences in mercury based on risk can translate into large outcome improvement, even though when you don't get to less than 140, much less than 130. So we did the ACCORD trial. This was a type 2 diabetic trial in over 10,000 type 2 adult diabetics who had diabetes a mean of about 8 to 10 years, who were followed for an A1C double-blindly to less than 6% or 7 to 7.9%. That's the topic of another day, but part of that group was relegated to a blood pressure arm or to a lipid arm. And I want to just show you the blood pressure arm. This was to a goal of less than 140. That was felt to be the evidence-based baseline, or less than 120. And the hypothesis was, in type 2 diabetics who had good overall cardiovascular risk reduction, would lowering their blood pressure to less than 120 improve cardiovascular outcome better than less than 140? We were able to get to less than 120. In fact, we got to a mean of 119, less than 140, starting at about 139, got down to 133.5. Patients came in on up to 2 antihypertensives. We had enough separation. The power was there. We should have been able to show that lower would have been better. We only needed 1.1 more medications to get to less than 120 compared to less than 140. So one caveat is when physicians say, I can never get my diabetics controlled, in the right setting where they got their medicines, they were seen every 2 months, they were called when they missed their appointment, they helped us help them to help others, the volunteer effect of being in a clinical trial, we could get blood pressure reduced to less than 120, and we did it very well in many different sites. But the primary outcome was not benefited, and this was a cardiovascular outcome for non-fatal MI, non-fatal stroke, or cardiovascular disease death. This goes to some of what Dr. Roberts was talking about last night. When I tell you that the LDL of these patients on a statin was 90, their A1C mean was 7.4, and now you're trying to show a cardiovascular benefit by blood pressure. Well, we couldn't show it. Not in that setting of good global risk reduction. But we did show the secondary endpoint of total stroke, a much more blood pressure dependent variable. But it was a secondary endpoint. Secondary endpoints beget future clinical trials. Primary endpoints drive clinical practice. So the New England Journal would not allow us to say much about stroke. And stroke remains often not talked about much in patients with diabetes. So this is what we found. We said that intensive antihypertensive therapy did not reduce the primary composite outcome versus less than 140 in patients with type 2 diabetes at high risk of cardiovascular events, but intensive antihypertensive therapy did reduce both total strokes and non-fatal stroke versus standard therapy, which were secondary endpoints, and there were more adverse events in the intensive group. So here's where we are. UK-PDS took us from 154 to 144. Outcome benefit improved. The advanced trial took us from 140 to 135, and ACCORD tells us we should get to 133. So it'll be interesting to see what JNC 8 says. I think they'll talk about all of this, and they might just say get to less than 130, because most of you are only going to get to 133, but they will talk about the evidence. And I think right now the evidence suggests that getting a systolic down to 133 in the setting of good global risk reduction is very important in patients with type 2 diabetes. But I still maintain that if they don't take a statin, their LDL isn't well controlled, and they're at high risk for stroke, perhaps even a lower blood pressure will minimize their risk. What does the ADA say? Well, they've changed their guideline because every year in January in Diabetes Care, they come up with their guideline and they publish it. First of all, for the diagnosis of hypertension, they say that it's 130 or greater, or a diastolic of 80 or greater, and you should repeat it. They have an asterisk next to the goal of less than 130 because this is the new important word, and it's individualization. There will be patients that you will get to less than 130 and perhaps some that you won't be as aggressive on, and they say that about the systolic. So the systolic of less than 130 is based on patient characteristics, response to therapy. Higher or lower systolic blood pressure targets may be appropriate. That's new wording. Less than 80 is still there from the HOT trial. What about chronic kidney disease? This is the African American study in kidney disease. Remember, less than 130 over less than 80 is the guideline. This was a well-designed trial in African American hypertensive patients with renal disease, and they looked at less than 140 over 90 versus 125 over 75 by mean arterial pressure. They actually achieved a 13 millimeter systolic difference and a 7 millimeter diastolic difference over 3 years, and they found no difference that lower was better on either cardiovascular or renal outcomes. But they followed up with a 10-year post-trial blood pressure. Here is the trial data, no difference. Here is the follow-up data, no difference. Here are both together, no difference. And here are the blood pressures we talked about. However, when you separate out in a subgroup analysis of those that had clinical proteinuria, in addition to their CKD, of 300 milligrams protein in the urine, macroalbuminuria, not macroalbuminuria, or more protein in the urine, now there's a benefit to the lower pressure. So, a recent Annals paper summarizes all of this, that the evidence does not conclusively show that the currently recommended blood pressure target of less than 130/80 improves clinical outcomes more than a conventional target of less than 140. A lower target may be beneficial in persons with proteinuria. We suggest that practitioners use discretion in patients with CKD and proteinuria and base the blood pressure target on individualized risk-benefit assessment. There's that word again, individualization. Treatment to a lower target may require greater vigilance to monitor for and avoid possible symptoms and adverse events from hypotension. So the party line is still less than 130/less than 80 in both type 2 diabetics and CKD, but perhaps this will be changed somewhat in JNC 8. What about the elderly? We're all told to get to less than 140/less than 90. A recent consensus paper changes that. Where systolic blood pressure values less than 140 are appropriate goals for most patients less than 80, for those 80 years of age and older, a goal of less than 150 is acceptable, aiming for 140 to 145. I don't have time to show you the evidence here, but this is exactly what the evidence says. We can talk about that in the breakout. Let's talk about the initial drug. I try to be a consensus builder. I've already told you that I think blood pressure reduction is more important than a particular agent in those without a compelling indication for a class of drug. I don't want to minimize the importance of lifestyle. And these are some new lifestyle recommendations that are going to be challenging to do. Clearly, without a dietitian at your right hand, it's going to be difficult for us to achieve these. We are being told to reduce sodium intake to less than 2,300 milligrams per day and to reduce it to 1,500 milligrams per day in all of those greater than 50 years of age, in all those who are African American, or those with hypertension, diabetes, or chronic kidney disease. And as Dr. Daniels has told you, the DASH, dietary approach to stop hypertension, which is high in fruit, vegetable, and low-fat and milk products, high in whole grains, poultry, seafood, and nuts, and low in sodium, high in potassium, low in red and processed meats, sweets, and sugar-containing beverages, is being recommended. In JNC 7, we recommended thiazide-type diuretics for most. Where did that come from? It came from the ALL-HAT trial. This was a government-led National Heart Lung Blood Institute trial, double-blind randomization of 42,000 North Americans, from Americans and Puerto Ricans who were in the trial, 623 centers. And the hypothesis was that although physicians were using sexier and more expensive drugs in the 80s and 90s, the hypothesis was that these drugs were better than the thiazide-diuretic chlorthalidone. It was a superiority trial, and it was negative. That is, amlodipine was not better than chlorthalidone, lisinopril was not better than chlorthalidone for the primary endpoint of fatal coronary heart disease or non-fatal MI. Of note, chlorthalidone was superior for a secondary endpoint of preventing first heart failure, that is, fatal, non-fatal, hospitalized or treated, or hospitalized or fatal heart failure. So we like to say that a thiazide diuretic should be part of the cocktail in those prone to heart failure or those with hypertension, and that's what this trial showed. Remember, the primary endpoint was equal. So why, now that these drugs are generic and are $4 per month, like chlorthalidone, we should say that thiazides are recommended for most is unclear because it's based on a secondary endpoint. And I already told you secondary endpoints are hypothesis generating, not practice driving. So we're a little schizophrenic in some of the data we look at compared to other, But I personally think that either a thiazide-type diuretic, a CCB, or an ACE or an ARB should be recommended as initial therapy. It's more important to get blood pressure reduced, and I think all three of these classes, or four classes, are excellent as initial therapy. The direct renin inhibitors, there's only one, aliskiren, still is waiting for where it should be used, and I don't think it has a lot of good data for initial therapy. Certainly it's being looked at in a large trial for renal protection and for cardiovascular protection. I do want to say a little bit about chlorthalidone, a thiazide-type diuretic, and compare it to HCTZ. I won't say much about indapamide, which is evidence-based. It's a indoline-type diuretic, and it's used a lot in Europe, and could be used at 1.25 to 2.5 milligrams a day. It's a $4 a month drug. I do want to talk about hydrochlorothiazide. Back in the day when some of you were younger in your practice, you were using 50 to 100 to up to 200 milligrams of hydrochlorothiazide. You were told this was a mistake. You were causing hypokalemia, metabolic abnormalities, side effects. And so we went to the times of low-dose thiazide, 12.5 to 25. Yes, it does reduce blood pressure, but 50 is better than 25, which is better than 12.5, but this is what we're using. And we have no evidence, none, that 12.5 or 25 of hydrochlorothiazide improves cardiovascular or cerebrovascular outcome. It does reduce blood pressure. We do have a lot of evidence from chlorthalidone. Remember, this is the thiazide used in SHEP with fatal and non-fatal stroke reduction compared to placebo, and in ALLHAT, where the outcome was the same as lisinopril and amlodipine at 12.5 to 25 and better for a secondary heart failure reduction. And in Mr. Fit, when they openly labeled centers to either hydrochlorothiazide or chlorthalidone, they found, the Data Monitoring Safety Board, that those on chlorthalidone were doing better, their outcomes were better, and they switched all the HCTZ centers to chlorthalidone. So we don't have strong data that chlorthalidone is better than hydrochlorothiazide for outcomes, but we do have a comparison, 24-hour ABPM of 50 of HCTZ compared to 25 of chlorthalidone. And although there was a trend of chlorthalidone being better during the day, there was a statistically significant benefit at night. Hydrochlorothiazide has a half-life of about 17 hours. Take it in the morning, you'll be unprotected for some hours of the night. Chlorthalidone hangs around for 24 to 40 hours. And that's why nighttime blood pressure is much better protected. So you'll see a lot about chlorthalidone, 12.5 to 25 in JNC 8. It doesn't come in a lot of combinations. We all like lisinopril hydrochlorothiazide for $4 a month, but this is a very strong area of debate right now in the hypertension community. As someone that left the VA a couple of years ago and now just sees patients with resistant hypertension, if you send me someone uncontrolled on hydrochlorothiazide, I will switch them to the same dose of chlorthalidone, because I'll come out looking like a hero. Because in this study in the Journal of Clinical Hypertension, those with resistant hypertension that just had HCTZ switched to chlorthalidone now had a significant better improvement in blood pressure reduction. So I think that this is an algorithm that I would support. I would mention that as long as you're not using atenolol once a day, beta blockers may be on this first tier, but the English NICE guidelines put it as a fourth tier. Pick your poison, use it. Up-titrate the dose, add another drug. If you're not at goal, use an alternative. These three classes are very nice as the first three classes, but I do want to show you something about mineralocorticoid receptor blocking drugs. You're not controlled on three drugs, including an ACE or an ARB, a CCB, and a diuretic. What do you do next? Well, in these 4 observational trials, all different, if you added spironolactone, 12.5 to 25, $4 a month, you know it as aldactone. As a fourth drug, this is the kind of systolic and diastolic reduction you got. So this is another trick I use in those with resistant hypertension, adding spironolactone as an additional drug. There's a lot of reactive hyperaldosteronism in our patients to what we do. They don't have Cohen syndrome, they don't have an adrenal tumor, but they have too much aldosterone and salt and water retention. Even without edema, the pipes are too full with volume. This drug is a great volume-reducing drug. These are the 6 compelling indications where we're compelled to use a particular class of drug in patients with hypertension. Mr. Jones has hypertension. He's on amlodipine. Now he comes in with an MI. His blood pressure is 108/72. I hold the amlodipine. I use an ACE and a beta blocker because in the MI setting, ACEs and beta blockers will improve outcome. Amlodipine has no evidence for that. I try to get some room for getting his blood pressure controlled, but getting those drugs on board. So in the compelling situation, we deal with those particular drugs. I don't think JNC 8 will have any new compelling situations. And finally, let me talk about combination therapy. We were taught in medical school that we should avoid combination tablets. We should up-titrate one drug, know what we're doing, know the side effects, add another drug. We know that most patients need 2 or more drugs to get controlled. These are the trials that you're all familiar with, the alphabet soup. Here are the diabetics. We tell you to get to less than 130. No clinical trial got to less than 130. Yet, irbesartan got an indication in type 2 diabetes with nephropathy. Look at how many drugs had to be used, how many drugs have to be used, how many drugs. The first drug in the cocktail of therapy to control blood pressure is rarely the final drug. Find the right cocktail for your patient. You may start with 2 drugs. Many of us are starting. I start about 8 out of 10 people on 2 drugs. If you still like to start with 1, fine, but just know you'll use 2 or more in most. And if you like to use an initial dose of a drug, and then you're going to up-titrate the dose, you'll find you'll get less blood pressure reduction than if you add another drug from another class. Case in point, your patient's on 12.5 of HCTZ. You want to go to 25. I'm going to add lisinopril HCT, 12.5. I'll get about 5 times more blood pressure reduction systolic than you will by doubling the dose. So this is a nice meta-analysis by Wall and colleagues showing that using 2 drugs is much more effective in lowering blood pressure than up-titrating the first drug. It's like the rule of 6s in lipids. You get the most bang for your buck with the first dose of the statin, and a little bit each time you go up in the dose. It's the same in blood pressure. Adding another drug from another class will give you more blood pressure reduction. We wrote this paper for the American Society of Hypertension. For blood pressure reduction, we prefer an ACE diuretic, an ARB diuretic, an ACCB, or an ARB-CCB. I don't have time here to go over all the nuances, but these are the 4 combinations that we like, either as 2 individual pills or as a fixed-dose combination. When do you start with a fixed dose? When they're 20/10 above goal. If your goal is less than 140/90 and your patient has stage 2 hypertension, 20/10, 1 drug won't get you there, you can start with 2 drugs. So, in summary, I've tried to make some predictions. We go back over 100 years to Sherlock Holmes. It is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. We've done that in hypertension. Keep an open mind. Keep looking at the data. It may change as hypertension evolves, especially with JNC 8. So in summary, it makes less difference which antihypertensive agent is used unless the patient has a compelling indication for a specific antihypertensive class, and matters more that blood pressure is appropriately reduced to your chosen blood pressure goal. The current recommended blood pressure goals in those with diabetes and CKD from the ADA, NKF, and JNC 7 is less than 130/80. Recent evidence may change the JNC 8 recommendations. The initial drug chosen, in my opinion, should be broadened to include a thiazide-diuretic, an ACE or an ARB, or a CCB. Certain drugs within the class may be preferred, and most patients will require 2 or more antihypertensive agents to get blood pressure effectively controlled, which may be best approached with initial combination therapy, either as a fixed-dose combination or as 2 individual agents, and price may have a bearing on that.